Assalamu alaikum and good evening. I, Dr. Sifat Tanjila, welcoming you all on today's live surgical CME on management of gastric cancer. Our today's CME is scientific partner Renata, media partner RAS TV, and powered by Vita D3 and Corazin D. Now I'd like to introduce our very honorable and panel expert. At first we have, and we are very much delighted to have Professor Dr. A.B.M. Jamal Sir, MBBS, FCPS General Surgery, FRCS from Royal College of Surgeons of England, Professor and Head of the Department of General Surgery, Dhaka Medical College. Sir, assalamu alaikum. Next we have Dr. Shubinoy Krishna Paul sir, Associate Professor, Unit Chief, Department of General Surgery, Surgery Unit 5, Dhaka Medical College. Sir, Adab.
Adab. Thank you.
Sir, thank you, sir. Next we have Dr. Naurin Sujana Aura, who is today's guest presenter on today's CME.
Thank you.
I'm requesting our panel expert to deliver their introductory speech based on today's topic. At first, I'd like to hear from Professor A.B.M. Jamal sir.
So it's nice to see everybody in this RAS TV online. And it's very important for both the undergraduate and postgraduate students and also the practicing surgeons. Carcinoma stomach is very common in our country. So we will be, all of us will be benefited from listening the different cases of carcinoma of the stomach, which will be presented by Dr. Naurin Sujana Aura. So let us start and let us hear her case first, then we'll discuss later.
Thank you, sir. Thanks a lot. Next, I would like to hear the introductory speech from Dr. Shubinoy Krishna Paul, sir.
Thank you, Tanjila. First of all, I convey my thanks to partner RAS TV media partner and the Renata Pharmaceuticals for their supporting us. Today's topic is the most important and common problem, both undergraduate as well as postgraduate for general surgical practice. That is the carcinoma of the stomach. There are so many pitfalls or so many diagnostic problems, and early detection of the cases is so important to manage the case and longevity of life. It will be discussed in these chapters. I hope Maureen will completely discuss this thing. After that, we, including the Jamal sir, they included this all aspects of gastric malignancy. Thank you, everyone.
Thank you, sir. Now I am seeking permission from our panel expert so that we can start the presentation.
Okay.
Thank you, sir. Dr. Naurin Sujana Aura, you can start your presentation.
Thank you, Dr. Sifat Apu. My respected teachers in the expert panel and dear audience, Assalamu alaikum and good afternoon. I am Dr. Naurin Sujana and I am welcoming you all to our today's CME on carcinoma stomach. I am going to present a case of a 60-year-old male with vomiting and weight loss. Starting with the particulars of the patient, Mr. Rashid Ahmed, 60 years old male, Muslim, banker by profession, hailing from Chandpur, admitted in Dhaka Medical College Hospital on 24th July 2020, and he was examined on the same day. He was presented to us with the complaints of loss of appetite for 5 months, weight loss for 5 months, and vomiting for 1 month. According to the patient's statement, he was apparently well 5 months back. Then he developed losing his appetite, which was associated with sensation of fullness after meals. During this period, he had lost 12 kg of body weight, which was about 1/5 of his previous one. Patient also complained of vomiting for last 1 month, occurring almost daily, about 4 to 6 hours after taking meal. It was projectile in nature, foul smelling, and sour in taste. Vomitus was clear in color and contained undigested and semi-digested food particles. Patient complained of passage of black tarry stool several times during last 1 month. He had no history of epigastric pain, fever, bone pain, and hemoptysis. His bowel and bladder habit was normal, other than passage of black tarry stool. He is non-diabetic, non-hypertensive, and non-asthmatic. There was no history of significant past medical or surgical illness. There was no history of any surgery or hospital admission. The patient does not take any medication on regular basis. He is a smoker, consumes about 10 to 15 cigarettes per day for the last 20 years. He is non-alcoholic and non-betel nut chewer. His parents have passed away but didn't have these types of symptoms during their life. None of his family members suffered from such type of illness. Patient is not allergic to any drug or food. He was immunized as per EPI schedule. Patient belongs to a middle-class family, lives in Paka house, drinks tap water, and uses sanitary latrine. Then when we examined the patient, on general examination, patient appeared to be ill-looking and anxious, but he was cooperative. Decubitus was on choice. Body build was below average as well as the nutritional status. Patient was moderately anemic, but there was no jaundice or cyanosis. Clubbing, koilonychia, leukonychia were absent. Edema was absent, but patient was moderately dehydrated. There was no engorged neck vein, no palpable accessible lymph node, bony tenderness was absent, and body hair distribution was normal. Moving on to the vitals, patient's pulse was 84 beats per minute, blood pressure was 130/80 millimeter of mercury, temperature was 98 degree Fahrenheit, and respiratory rate was 16 breaths per minute. On inspection of abdomen, it was flat in shape, flanks were not full, umbilicus was centrally placed and inverted. Hair distribution was normal. Hernial orifices were intact. There was no visible peristalsis and pulsation, no incisional scar marks, no engorged vein or pigmentation. On superficial palpation, temperature of abdomen was not raised. There was no muscle guarding or tenderness. On deep palpation, there was a lump in the epigastric region measuring about 5 cm by 4 cm in diameter, globular in shape, with well-defined margin and a smooth surface. It was non-tender, firm in consistency, and moves outward and downward with respiration. In head rising test, it reduces in size, while in knee elbow test, it increases in size. Other areas of abdomen were normal. Succussion splash was positive. Liver, spleen, urinary bladder, and kidney were not palpable. Para-aortic lymph nodes were also not palpable. External genitalia was normal. Percussion note over the lump was dull. In other areas, it was tympanic. Shifting dullness was absent. Upper border of liver dullness was found in the right fifth intercostal space along the mid-clavicular line. On auscultation, bowel sound was present. There was no added sound. Parectal examination reveals no abnormality. Examination of the cardiovascular system, respiratory system, genitourinary system, nervous system, locomotor system were normal. So, to summarize, Mr. Rashid Ahmed, 60 years old of age, smoker male, hailing from a middle-class family of Chandpur, admitted into Dhaka Medical College Hospital under surgery department on 24th July 2020 with the complaints of loss of appetite for 5 months, associated with sense of fullness after meals. During this period, he had history of significant weight loss. During this last 1 month, patient had vomiting occurring almost daily, about 4 to 6 hours after meals. It was spontaneous, projectile in nature, foul smelling, and sour in taste. Vomitus was clear in color, containing undigested and semi-digested food particles. He had no history of epigastric pain, hematemesis, alteration of bowel habit, hematuria, hemoptysis, and bone pain. He had no previous history of same type of illness, no previous surgical intervention, no positive family history, and no history of regular medication. On general examination, the patient was ill-looking, anxious, moderately anemic, and dehydrated, but he had no jaundice, cyanosis, edema, lymphadenopathy, clubbing, fever, or tachycardia. His nutritional status was below average. On local examination of abdomen, there was a palpable lump which was non-tender, smooth, and firm. Other areas of his abdomen was normal, with no organomegaly, ascites, or abnormal findings in diarrhea. Other system examination findings were normal. So, our provisional diagnosis was carcinoma stomach. We put on some differentials like pyloric stenosis, carcinoma transverse colon, and gastrointestinal stromal tumor. To exclude the differentials, we advised some investigations. The most important one is the endoscopy of upper GIT, including the biopsy. In endoscopy, a large friable growth with contact bleeding involving the lower body and antrum was found. Pylorus is narrowed and a scope could be passed into bulb with some effort. Biopsy is taken from the growth. Features are suggestive of carcinoma stomach. This is the endoscopy. Here the growth is. And histopathology report says that it is a poorly differentiated adenocarcinoma grade 2. We advise some supporting investigations, including the complete blood count, which reveals hemoglobin is markedly reduced while ESR is mildly raised. Total and differential counts of WBC were normal. Serum electrolyte where all the parameters were below average, like there was hyponatremia, hypokalemia, and hypochloremia. These are the staging investigations. Chest X-ray and X-ray of dorsolumbar spine were normal. But in the contrast-enhanced CT scan of abdomen, there were marked irregular thickening of the wall of the lower part of the body, pyloric antrum, and pyloric canal of the stomach. Here we can see that the canal of the stomach is narrowed by the growth. It is marked with the arrows. Liver function tests were normal. So our clinical diagnosis was adenocarcinoma of pyloric part of stomach. Our plan of management includes preoperative preparation and plan of surgery. Preoperative preparation includes preparation for pre-anesthetic checkup and optimization for surgery. And our plan of surgery was lower partial gastrectomy with gastrojejunostomy. So we prepared the patient for PACU with the investigations like random blood sugar, serum creatinine, serum albumin, and all of them were within normal limit. Echocardiography and ECG were also normal. HbS antigen and RT-PCR for COVID-19 were negative. Optimization of the patient for surgery includes patient preparation and stomach preparation. We have corrected the dehydration and electrolyte imbalance with normal saline infusion along with injection KT, and correction of anemia was done with blood transfusion. Correction of a nutritional status was done. Stomach preparation was done with gastric lavage 3 days prior to surgery with wide-bore orogastric or nasogastric tube. Exploratory laparotomy was done on 7th August 2020. Paroperatively, a large irregular growth in the lower part of the body and pyloric antrum of the stomach, measuring about 7 by 6 cm and 8 cm away from gastroesophageal junction. So lower partial gastrectomy was done with resection of distal stomach along with the growth. Resection margin was proximally 5 cm from the growth, and distally it was 2 cm from the growth. Continuity was maintained by gastrojejunostomy. Here, in this picture, we can see that the pylorus and antrum, these things were removed, and then the loop of jejunum were brought closer to the stomach, and a gastrojejunostomy was done. This is also known as Billroth 2. So, when we found the histopathology report, it says that poorly differentiated adenocarcinoma of pyloric part of stomach, which was in T2 stage. So we reached through our final diagnosis of adenocarcinoma of pyloric part of stomach. Postoperatively, the patient was managed with chemotherapy, including 5-fluorouracil and cisplatin. Follow-up to be done every 4 months up to 1 year, every 6 months for next 2 years, and then annually. 5-year survival is seen in about 90% of patients after successful surgery in early stage. So that's all about the case today. Thank you for your patience and your valuable time.
For the very nice and lively presentation. Now I am requesting our panel expert to give their valuable opinion regarding this presentation. At first, I'd like to hear from Professor Dr. A.B.M. Jamal, sir.
So thank you, Dr. Noreen. It's a very typical case. Actually, a lot of patients in our country comes with this like advanced cases with palpable lump in the abdomen. And when a carcinoma of the stomach patient presents with palpable lump, actually it's a pretty advanced stage, and there is very little scope to remove all the tumor tissue along with clear radical clearance of the margins. But in this particular case, patient is very lucky enough, despite there is very large lump and with associated symptoms of long-standing vomiting and weight loss. Patient's surgery could be possible, and surgery has been done, and the correct method was done also. If we think about the presentation of carcinoma of the stomach presents from very early stage to that of the very advanced stage. Even some countries in the world, carcinoma of the stomach can be diagnosed as a screening procedure, like in Japan and China and mostly Korean belt. So, but in our country, people are not so much concerned or so much aware when a patient usually get advice for operative treatment or something like that. The patient usually comes in a very advanced stage, and the patient shows with some forms of anemia, weight loss, or presence of lump. Even some patients we can get in the stage of ascites or abdominal distension. Even some patients in patients with intestinal obstruction like features also. If we consider that carcinoma of the stomach is not very uncommon, and day by day its incidence is gradually increasing, not only in our country but also in many countries like us. So we have to think about some of the factors related to this occurrence of the carcinoma of the stomach and some of the pre-malignant condition as well. In this particular case, we think that there are certain factors present in this particular case. Patient age is also in favor of this carcinoma of the stomach, and he is a non-smoker. It's very important. Smokers usually suffer more than that of the non-smoker group, and male patients also suffer in comparison to that of the female counterpart. And if we see that in our country, acid-lowering drugs are very common, and people usually take acid-lowering drugs without the prescription of a gastroenterologist or a competent physician, and they took this medicine wherever and whenever indicated or even not indicated. So they're just taking their anti-ulcerant drug and acid-lowering agents also. So what happened in this particular condition that aclohydria developed, and long-standing aclohydria acid is not always detrimental for people's normal health. Acid is very useful, and acid is also a protective things against the carcinoma development. So this is very important. So people thinking is that acid is always detrimental for his health, so we have to lower our acid content in the stomach. But actually, a certain level of acid is very helpful for our digestion, not only digestion, but also to maintain the internal milieu of the gastric mucosa and gastric lumen. So, acid is also very helpful for our normal day-to-day life activity. But people thinking is that when he develops some dyspeptic symptoms or he develops some non-ulcer dyspepsia, he used to think that this should be immediately counteracted by acid-loading drugs. And what happened? The continuous use of these acid-loading drugs leads to achlorhydria. Achlorhydria is nothing but complete absence of chlorine production. At one stage, there is metaplasia of the gastric mucosa, and this metaplasia leads to the pre-malignant condition, that means the neoplasia or dysplastic syndrome, gastric dysplastic syndrome. So this dysplasia ultimately, in long run, will develop carcinoma. So in our country, this is also very important factor. But what is our observation is that many of the patients in our country, gastric carcinoma, are patients from the coastal belt, especially those who live around the Bay of Bengal and other large rivers side. So they used to take the smoked fish, and they used to take also some of the fishes that is not properly cooked. So semi-cooked or uncooked fish even, and some of the dried fish also for long-standing, melted with salts and other chemicals. So these are not very suitable for us, and long-standing uh, habits of using these kinds of fish and fish products is detrimental for our health, and this acts as a factor for promoting the carcinoma of the stomach. If there are some studies in our coastal belts that those who continuously eat the smoked fish or the dried fish or with mixed with salt, so they are more liable to develop the carcinoma of the stomach. So it's a health hazard and environmental factor. So everybody should concern about these kinds of health hazards. Regarding this particular case, if we saw the case records from of these patients, the procedure done or the investigative way out or diagnostic workup was absolutely in line of the scientific management of the carcinoma of the stomach. And we know that nowadays endoscopy of the upper GI tract is common almost every district hospital or district level hospital also. So this is the main armamentum of the diagnosis of carcinoma of the stomach, that is endoscopy of the upper GI tract. And the availability of a good and an expert, competent gastroenterologist or endoscopist is the vital role or key points in this particular case. You know that many of our doctors see in our ward setting that if not properly done, the endoscopy, then we frequently fail to obtain the tissue for diagnosis in case of carcinoma of the stomach. So this is a just a important point that endoscopy should be done by a competent hand. And endoscopy is not a very easy investigation. It is invasive types of investigation. That means it needs some special medication, it needs some special expertise, and it is not so soothing what the person who is undergoing for endoscopic examination. So whenever indicated, it should be done by an expert hand. That single shot endoscopy or single shot take of biopsy is very important. Another investigation is of much more helpful for the management of carcinoma of the stomach is the CT scan of the whole abdomen. We call it CECT. That means contrast enhanced CT scan. This is also very important for management plan or operative procedure plan or whether a patient should be first managed by the surgical means or first by chemotherapy or by any other means. So CECT is also very important, and availability of CECT is now almost every district or district level hospitals or diagnostic centers. So these two investigation is the most important and vital. Some of the investigation are very additive investigation we can do. It's not for the absolute management plan, but for the to see the prognosis, to see the to evaluate the follow-up procedures like the tumor markers and also the extra chest. These are very important, and ultrasonography, the whole abdomen also gives some clue whether the patient has got any distant metastasis or intra-abdominal metastasis or any other invasion from the gastric tissue to the surrounding other vital structure like pancreas, colon, liver, or even small intestine. So these are the very important investigation. Surgical option, most of the time, the removal of the tumor is the mainstay of the treatment of any malignant tumor if it appears as a solid lump. And in that case, the partial gastrectomy, lower partial gastrectomy was absolutely the right treatment for this particular patient. If the growth involves the body, middle part of the body, and even the upper quadrants of the stomach, in that particular case, we may proceed for total gastrectomy or radical gastrectomy as well. But in this particular case, as the growth is confined to that of the lower part of the stomach, so lower partial gastrectomy is good enough for surgical management. One thing I want to emphasize for the better management of the stomach is that there is no single shot treatment policy for carcinoma of the stomach. So surgery is a part of a combination therapy. So, and surgery is the mainstay of the treatment of the carcinoma of the stomach. A patient should not think that after removal of his tumor, his treatment is complete. He should be managed by some other means like chemotherapy, and he should be followed up for his lifelong time, whether there is any recurrence or there is complete removal of the malignant growth. And as we have seen in the diagram that much of the stomach gastric tissue remains in a patient's body, and its anastomosis with that of the jejunum. So there is every possibilities of development of further malignancy in the remaining part of the stomach, because the pre-malignant condition or the predisposing factors, those remain for the lifetimes, and those runs with the patient's life expectancy. So this should be also considered during the management of the carcinoma of the stomach. And lifelong follow-up, we called it lifelong follow-up, is very important. And though this is a little bit burden for the patient's economical aspects, but it should be done, because once it recurs, it is very difficult to operate in second time for a growth of the carcinoma of the stomach. So it's important to follow the patient so that every chance of very early recurrence, diagnosis of very early recurrence is very important, so that we can manage by chemotherapy and some other means. So with this little comments, I want to conclude my comments of this particular case reports on carcinoma of the stomach. Thank you.
Thank you, sir. Thanks for your valuable opinion. Next, I would like to hear from Dr. Shubina Krishna Paul, sir, about today's presentation and what are the diagnostic measures we can take in case of carcinoma stomach. It would be very nice if you elaborately describe all the things with us.
Thank you, Tanjila. First of all, I congratulate Maureen, as because our presentation is very excellent, as it's a typical presentation of a PS stomach. That is the all ingredient of diagnosis is within her history. History completed the all aspects, as because patient is 60 years age. History, short history, that is 5 months history, and weight loss, anorexia. In addition to this, there is an melena, that is black tarry stool, vomiting, and every features are in favor of positive history on gastric malignancy. There is a short history, elderly age, anorexia, weight loss, that is significant weight loss, 12 within 5 months, the patient loses the 12 kg weight, vomiting, everything is in favor of positive history of gastric malignancy. But on examination, only the dehydration was the positive history on general examination. But she mentioned on deep palpation there is an epigastric lump. But I think during operation, his clinical finding is not such correlate with the operative finding, as because Jamal sir already mentioned that when you palpable lump is found in a patient, in a gastric cancer patient, we think that is the advanced thing, that is pain or adjacent structure is involved or momentum over the humerus area or infiltrate the local structure like colon or pancreas. But in these cases, during surgical procedure, we found that the patient having the tumor located within the pyloric area and antral part without involving the surrounding structures. So, in these features is not so much correlated with the clinical finding. That is the one pitfall. Another history, that is the patient having the history of melena for the last 5 months. So obviously patient having blood loss, but by this 5 months time, does the patient have any history of blood transfusion or a?
No, sir. Melena is not for 5 months. It's only for 1 month and 1 month. Yes.
So 1 month, but no history of hematemesis.
No history of hematemesis.
Oh, the frank melena, that needs also some sorts of blood transfusion, as because patient having the 8 gram hemoglobin on admission. By this time, 1 month history of melena, obviously patient losing some blood. That's why it may patient needed blood transfusion. Okay. Next one is
or 2 units of blood already transfused and anemia is corrected before the surgery.
Okay, that should be mentioned. That is the patient having any blood transfusion or not, or having blood products. That should be mentioned. Okay. Next one is the regarding investigation. Investigation, you just state the investigation. That is the diagnostic investigation. Okay. You first do the endoscopy, and rightly mentioning the ultraproliferative growth in the pyloric area and biopsy scope. Next one, when we diagnose the case of malignancy, whether it is gastric malignancy or any other malignancy, next steps of investigation is the staging investigation. And in this case, what are the staging investigations? You rightly mentioning that the CECT, it is one of the aids, that is the CECT. By the CT scan, we detect whether the tumor is locally involved or the relationship of the stomach and lesion to the surrounding structures, or peritoneal dissemination, or seedlings or liver involvement. Okay. Next, we can use the endoscopic, that is the endoscopic ultrasound, that is the luminal ultrasound, that can help the local invasion of the tumor. It rightly can detect us how much embed the surrounding structure. And X-ray test is another way to detect the dissemination in the lung. Rightly, that the CT scan of the chest. And these are these investigations of the under heading of the investigation for stage of the disease. That is the clinical stage. Now we decide whether this patient is operable or non-operable. If operable, and which operation we offer for the patient, whether it is the curative surgery or it is the palliative surgery. Because clinically we found the lump, so there is a doubt whether it is advanced stage, whether curative surgery is possible or not. But CT scan shows no involvement of the surrounding structures, tumor related to tumor involve only the antral part, the thickening of the antral area and narrowed area, but other structure is free from any involvement. So pre-operatively we decided that we can offer this patient for the curative surgery, that is the lower distal radical gastrectomy. In this case, you mentioning that the exploratory laparotomy is rightly right thing is not the exploratory laparotomy. It is the operation, that is the intention, with intention of the curative surgery, we do the laparotomy, not the exploratory laparotomy. Exploratory laparotomy is we use when there is a diagnosis is doubtful, intra-abdominal pathology is unclear. In that case, the laparotomy we do the exploratory laparotomy, like in perforation or hollow discharge. Which type of perforation we don't know. We think that is the bile, that is the gastric, duodenal, or any other hollow discharge. In that case, diagnosis is the preoperatively unclear, and laparotomy we do for the clearance. That laparotomy is for the exploratory. But planned laparotomy is not the exploratory. So you don't mention here as an exploratory laparotomy. In these cases, we do the laparotomy. We did the laparotomy for the curative intention of gastric tumor, that is the lower radical gastrectomy. And these types of after laparotomy, then you start whole of the abdomen, including distal area, that is the all of the peritoneum, liver, pelvis, any dissemination in the pelvic floor, then come to the local area, whether the tumor is limited within the stomach, within lumen or wall, or surrounding structures in them. If the free from surrounding structure, no distal involvement, no dissemination, only the lymph node and distal part of the stomach is involved, in that cases we go for the lower radical gastrectomy, including the lymph nodes, all lymph nodes, first tier and one step ahead. If it is the T1, T2 stage involving the paragastric lymph node as well as second tier lymph node, that is the R0 resection. R0 resection means we resect the tumor with the intention of curative, that is the total clearance of the disease. Tumor as well as draining lymph nodes all are removed. That is the R0 resection. If R0 resection is not possible, that is the R1 resection or R2 resection. If nothing is possible, that is the curative resection is not possible, in that case only just palliative gastrectomy. Palliative surgery depends on state of the disease as well as state of the patient, general condition of the patient. And another option is the no palliative gastrectomy is possible. In that case, only drainage, only the symptomatic, that is the either the bleeding or there is obstruction, in the case only gastroenterostomy. All of the stomach is involved. In that case, we just do the feeding jejunostomy. But this case is favorable for the lower partial gastrectomy. That the decision is all right, and the patient receive the actual already the standard treatment, that is the lower partial gastrectomy with perigastric lymphodectomy. After operation, that is surgical treatment, then we provide the patient for the further management. Further management is what? That is the post-operative chemo radiation, that is the adjuvant chemo or radiation. Radiation is not important here, but the adjuvant chemo is most important for elimination of the rest of the tumor seedling that is not macroscopically visible, but macroscopically there are so many deposits that is not obvious. For that purpose, the oncologist will consult with oncologist, that is the multidisciplinary approach. Surgery is done, but surgery is not only the curative way. After curative surgery or palliative surgery, patient will get the further treatment, that is the chemo treatment, that is the palliative chemo, or that is the curative treatment. This is the way of managing this gastric malignancy. You're rightly mentioning everything, and your diagnosis as well as the investigation protocol is only within normal protocol, accepting few deviation like this exploratory laboratory and some few points. Otherwise, your presentation and your management protocol is everything. Thank you very much for your nice presentation.
Thank you, sir.
Thank you, sir, for your valuable opinion. Dear audience, if you wanted to know anything, any question or any query from our valuable panel experts, you can put your question in the comment below. I will present the questions to our panel experts. Next, I would like to hear from Honorable Professor Dr. A.B.N. Jama, sir. Sir, Dr. Shubhina Krishnapal, sir, already have discussed about the management and some sorts of investigation. You have already discussed about the various diagnostic modalities. So, sir, I'd like to get some final comments about diagnosis of this disease and other management options about this disease. Sir, it would be very nice if you describe all the diagnosis, all the management treat modalities, and all the management options with us.
Thank you, Dr. Shifat. I just want to mention some few points, notable points for the general people or for the general practitioners, especially the younger doctors, about the early features of carcinoma of the stomach. So we should all aware that when a patient presents with lump or ascites, it's pretty advanced, and there is very little to do for these patients, either surgical or chemotherapy treatment. So early diagnosis is very important for carcinoma of the stomach, and we should keep in our mind some of the features which may lead or may dictate to that this patient might be a case of carcinoma of the stomach. First of all, if we think that a patient after age of 40 or 50 develop dyspepsia for the first time, we should take it very seriously. So new dyspepsia after 40 or 50, a patient doesn't have any peptic ulcer-like symptom, does not have any non-ulcer dyspepsia, even early part of his life time, but suddenly he develops dyspepsia. So this should be a remarkable important points to consider that this patient might develop gastric malignancy. So this is a very early feature. Another important feature, early feature, notable feature, we should think that postprandial epigastric fullness. That means some patients complain that he feels some forms of fullness in the upper part of the abdomen, mostly in the central part of the epigastrium, or somehow in this region. After meal, he develops the fullness, like fullness after meal. Even some patients may notice that when he wants to take a full plates of rice or some other things, he doesn't complete his full plate of meal. After taking half or quarter part of his plate, he doesn't feel any interest to take rest of his meal. So this is very important, that a postprandial epigastric fullness, and it is not a single occasion. If it's continuous for few days, we should keep very seriously that this is very important early features of carcinoma of the stomach. Third one, I want to mention that some of the patients, we know that in this subcontinent, we are very fond of taking meat and meat products. So when a patient takes meat products like beef or mutton, if he used to take beef or mutton twice or three times in a week regularly, and suddenly he feels that from the last 1 or 2 weeks, he doesn't have any interest of taking any meat or meat product like beef or mutton, or beef or mutton made some other food particle also. So this is very remarkable, and this should be considered in mind that this patient might develop a early gastric carcinoma. Fourth one, I want to mention that an elderly person after 50 years, if he develops unexplained weakness, and easy fatigability. These two, combination of these two, that unexplained weakness, easy fatigability. How can we explain the unexplained weakness? Suppose a patient can walk to his office about 1 or 2 kilometers of his workplace for 1 or 2 kilometers without taking any rest. Suddenly, from last 1 or 2 weeks or last month, he feels that within this 2-kilometer walking, he has to force to take rest once or twice. Or a person is driving a bus or truck or some other vehicle. He just needs to take some rest and some. He has forced to take some rest after driving 1 hour or 2 hours. So it should be considered that this is a feature of easy fatigability and easy weakness. So easy fatigability and easy weakness should be considered that this might be a important clue that this patient may develop carcinoma of the stomach. So these 4 or 5 important points that should be considered if you want to diagnose the carcinoma of the stomach at its earliest possible time. So with these few words, I want to conclude, and I want to express my gratitude to Renata Limited as well as Raj TV for inviting me and including me as a panelist and to say something in front of the audience. Thank you.
Thank you,
Thank you, sir. Thanks a lot. Sir, we have some questions from the audience. Dr. Devashish Bor, Dada, wanted to know why carcinoma stomach is more common in cardia in Western world.
Actually, there are some geographical variations of the carcinoma of the stomach happening in different quadrant or different parts of the stomach. If we consider that a stomach is actually a very voluminous and large structure, and its length is also is remarkable, and it's a structure, not only the abdominal structure, some parts of the stomach extends to that of the thoracic cavity as well. So starting from the gastroesophageal junction to that of the pylorus, there are different zones, and the histological natures of different zones are a little bit different to that of the other zones. And there are also distributions of the gastric glands and gastric secretory cells in different zones by the different region, and their behavior is also different. So in some parts of the world, carcinoma of the stomach, we see that antral growth is more common, like in our subcontinent. But in some parts of the world, in Western world, their food habit is a little bit different. They are very much fond of alcohol. They are very much fond of smoked food, tinned food, canned foods. So this food habit may lead to that of the development of carcinoma. So more in Western world, in cardiac, fundus, or upper parts of the stomach.
Thank you, sir. Next, we have another question from Dr. Shojib. Is inoperable any role of stenting or recanalization?
Actually, there are various new methods they are planning to recanalize, like fulguration. And endoscopic fulguration is one of the trying methods, and laser fulguration is also important. But these are not so much useful till today. We hope that in near future it will be a better hope for all of us. But till today, in an inoperable or completely occluded lumen, we should have an alternate procedure like fitting jejunostomy, or there should be a bypass, different types of bypass, if possible.
Yes,
yes, with the growth remain at the same place as well. So these are the possibilities. Actually, very advanced case, it's not very suitable.
Thank you, sir. We have next question. I'd like to hear the answer from Dr. Shubhina Krishnapal, sir. Sir, what is the management option in case of T4 carcinoma, gastric carcinoma?
Carcinoma stomach management plan, that is, we decided the management plan. We decided the management plan according to stage of disease. First of all, After diagnosis, we have already mentioned that after diagnosis, it's a case of carcinoma. Then next steps is what is the clinical staging. After performing the clinical staging, we decided the treatment options. If it is in early stage, in that case, curative surgery is offered, and it is the best result on curative surgery. If the patient is present early stage, we remove the stomach, that is the, if it is distal part, distal radical gastrectomy. If it is involved the whole of the stomach, that is the total radical gastrectomy. If it is in the upper part limited, that is the upper radical or lower radical, or any sorts of surgery, including the draining lymph nodes. And on R0 resection, always one stage ahead, that is the draining lymph node. If it is the paragastric lymph node, then we consider the second tier of lymph node as an curative intention. That is the early gastric carcinoma. In case of advanced gastric malignancy, in that case is the either palliative gastrectomy or other palliative measures. If there is an obstruction, is the main symptoms with advanced gastric malignancy involving the liver or any distant metastasis. In that cases, only the palliation is enough. That is the in a palliation in the form of outlet obstruction, either gastrojejunostomy or any tubing or channeling or removing the obstruction. Where the whole of the stomach or main almost two-thirds or more than two-thirds of the stomach is involved, where the gastrojejunostomy is not possible. In that case, only the feeding jejunostomy is enough for this patient. As because of we know that the gastric malignancy is one of the aggressive malignancy. Like after hepatobiliary malignancy, next aggressive malignancy is the gastric malignancy. When we do the curative surgery, in that case, a 5-year survival rate only 50%. In advanced cases, 5-year survival rate only few percentage, that is the 10 to 20%. So the majority cases in advanced gastric malignancy, we do not go for the major surgical procedures. Only the palliative measures we take off. In addition to this, that chemotherapy is another option with consideration of the involvement. And this is the few options, that is the curative as well as the palliative. Palliative within the palliative, either palliative surgical resection or only palliative bypass. And last of all, that the feeding jejunostomy or feeding any feeding measures, palliative feeding measures. That's this is the principles of management of a surgical option. Then we decided whether this patient is receiving the palliative chemo. Sometimes palliative radiotherapy less effective in case of gastric malignancy, but chemotherapy is sometimes effective. In advanced cases, mortality is very high, so we don't go for or decide for major surgical procedures. That surgical procedures may lead to the shortening of patient's life in surgery-related complications. So decision is very much important, as because of patient become malnourished, anemic, weight loss থাকে, and these provided less outcome of the major surgical procedures. Only the benefited palliative surgical procedures we offer these patients.
Thank you, sir. Next, we have another question. May we get clarification regarding inoperable and irresectable in regard of gastric carcinoma?
Sorry?
May we get clarification regarding inoperable or irresectable in regard of gastric carcinoma?
In case of irresectable or inoperable gastric malignancy, just we go for the palliative gastrojejunostomy. Otherwise, major, that is a resection, partial resection, total resection, no go for such types of surgeries. Only for the palliative tube feeding, the jejunal feeding, that is the tube jejunostomy.
Sir, next question is there any role doing downstaging by neoadjuvant chemotherapy and then going for debulking surgery?
Yes, yes. There is a rule, that is the neoadjuvant chemotherapy. If the patient is younger, patient histopathology report is favorable, that is not anaplastic variety or not in signet form, not in mucin secreting, there is simple adenocarcinoma. A younger age group, involving part is the distal part, not involving the surrounding structures. In that cases, neoadjuvant chemotherapy downstages the patient, and we go for the radical gastrectomy, either partial or total, with intention of the curative, that is including other perigastric lymph nodes and next tiers lymph nodes, followed by the adjuvant chemo.
Thank you, sir. Next, I would like to hear from Honorable Professor Dr. APM Jamal, sir. Next question from Dr. Nasreen Jaman. Thank you. Nice presentation. Please discuss prognosis of this patient.
Prognosis, by this time we have already mentioned in our discussion the different stages of the prognosis. In this particular carcinoma of the stomach, if there is pretty advanced case, there is a big lump, actually prognosis is not so good. Even oncologists, especially the medical oncologists, are very reluctant to deal with these kinds of huge lump, and they frequently advise to do some sorts of surgical treatment first, then for the chemotherapy later on. If we think that Dr. Shubina has already mentioned that neoadjuvant chemotherapy has a role in younger patients, but this has also some limitation, neoadjuvant chemotherapy. If the lump is very large enough, it's invaded the structure, then neoadjuvant chemotherapy usually doesn't have a very good role or good option for that, for those cases. So what to do? It's for junior doctors and for the lay peoples that the early reporting and early presentation and early consultation is the most important thing in case of the carcinoma of the stomach. Another important thing, one of the doctor asked a question to Dr. Shubina that what will we do if there is a very inoperable or advanced case. Nowadays, we don't go for any surgical procedure without doing a CECT. A CECT, a good quality CECT, can clearly dictate which patients have got some benefits in surgical procedure. If those patients have no chance of any proven benefits after surgical procedure, just for try, we don't go for surgery. Usually what we do, we have to offer some palliative treatment like feeding jejunostomy or some forms of PEG, percutaneous endoscopic gastroscopy, or if patient desires some form of palliative bypass, or if patients already develop jaundice, then the treatment of the obstructive jaundice in that line. So just for taking a chance whether it can be done, this is not a good option for the advanced case of carcinoma of the stomach. And a good quality CT scan can clearly mention which patients may get some benefits after going for laparotomy or not. In this context, I also want to mention that the role of the tumor board is very important in the management of the carcinoma of the stomach. A good tumor board and a good discussion among the participants of the tumor board can clearly detect the flow charts of the management of individual patients. And this is the most important things and most vital things in the management of the carcinoma of the stomach.
Thank you, sir. Next question is, what are the treatment modalities if D3 tire involves?
If
D3 tire involves.
Okay, that means it's pretty advanced case. So as it is pretty advanced case, so I have already mentioned different ways of management of advanced case. So those option, one of those option, usually the surgeon choose one of those option with the consultation of the patients and his attendants. This is the best option.
Thank you, sir. Next question, probably is the last question. Did we do distal pancreatectomy and splenectomy along with hilar lymph node dissection nowadays in case of radical gastrectomy?
So spleen is nothing but another lymph nodes. It's a lymphatic organ. So there is no advantage of removing of the spleen isolately, getting a chance that this patient might get a benefit. If we are not able to remove all the tires of the lymph nodes,
exactly,
that's
sir.
very important. If
Yes,
there
sir.
is impossible to remove the tires of the lymph nodes, there is no role of removing the spleen or the distal pancreas, and it will just increase the postoperative morbidity of this patient.
Morbidity, exactly.
So this is the most important. We cannot add the morbidity by doing the removal of the
Surgery.
another organ as well. So this is the most important.
Sir, in that case, omentectomy we can do or not?
Omentectomy is an operation mainly suitable for malignancy of the lower abdomen or pelvic region, because you know the greater omentum has an extension from the upper part of abdomen to that of the pelvis, and many a time these long course of the greater omentum may adhere with that of the tumor tissue in the lower part of the abdomen, like uterus, ovary, appendix, or colon. So it will produce the intestinal obstruction. So to prevent the intestinal obstruction and to prevent that, we also know that greater omentum is a highly vascularized organ. So it's a good site for development of the metastasis later on. So to prevent those metastasis and intestinal obstruction, infracolic omentectomy, we should not call it total omentectomy. Supracolic omentectomy should not be done. It should be infracolic omentectomy can be added as a preventive measure for development of metastasis or development of intestinal obstruction.
Sir, we have another question. If you give permission, then I can present the question.
Okay, sure. You can ask Shubinoy. Shubinoy can answer.
Okay. So Dr. Shubinoy Krishnapal sir, next question is for you. If recurrence occur in the stomach bed, what are the treatment modalities?
Recurrence occurring in the stomach bed means the stomach bed formed by the pancreas, undoubtedly. So pancreatic involvement. Is it not? After surgery, if in the follow-up, CT shows that the involvement of the stomach bed, that is the pancreas, is involved. In that case, is no other surgical option. So we then go for the adjuvant chemotherapy. In that cases, we offer for the adjuvant chemotherapy. Or every cases, sir have already mentioned, that is the tumor board, and discussion with the other colleagues of surgical as well as tumor management, that should be important. We should make a board in that cases, or in every cases of cancer patient, we make the board surgeon, radiotherapist, or radiologist, pathologist, and other surgical colleagues. This forms a integrated tumor board, and tumor board decided the every corners of management and better options of management. That is the A, B, C, D, E. What are the options, and which options is more preferable in the particular cases? This particular option is not all options are applicable in every patient, but we offer the maximum benefited options for that particular case. That is individualization of the treatment policies. That is important. So most of the cases, our weapons of the management, that is on surgery as well as chemo, either neoadjuvant, that is small role, and neoadjuvant, as well as adjuvant chemo. These two weapon we managing the gastric malignancy. But at the end of my discussion, that is one thing is important and mention everybody, that is the gastric malignancy is dangerous, aggressive. So any source of treatment options is not so much benefited for the patient until the patient is recovered, or until the patient is detected in early stage, which is only possible by screening endoscopy, which is done on the Western, that is the Eastern country, Eastern world, that is the Japan. They follow the 6-month interval, they undergoing the endoscopic follow-up. they like our ECG, that is the cardiac follow-up. We do the cardiac follow-up by the ECG. They do the endoscopy in the bedside. Most of the doctors who do the endoscopy. So the follow-up endoscopy is very much important. Screening endoscopy is very much important. We do the endoscopy in a patient in a lifetime 1 or 2 times. That's why we diagnose the case at the later stage. When it is obvious that is lump is visible, in that case, is patient present to us by ultrasonography or by CT scan or any other measure. When everybody can say yes, patient having the tumor, but it is in at that stage when nothing is possible, nothing is benefited for the patient. Most of the cases in our surgery hospital practice or our day-to-day practice, most of the patient present like this scenario. That is, they present us in a late stages, the late but advanced late. That's why no treatment is benefited, no treatment is beneficial for this patient. So we have to, our future doctors should have aim to diagnose the case in as early as possible. So sir already mentioning 4 important points, that is the new dyspepsia and weakness, asthenia after 40, just few symptoms. That is the clue. So good clinician can respect these few symptoms. They must do the endoscopy, at least one investigation, not do the ultrasound or any other investigation, only one investigation related to these early symptoms, that is the endoscopy. Endoscopy can detect this early stage of gastric cancer, and in that early stage we can provide the maximum benefit for these cancer bearing patients. That's the important message. I think everybody, our new doctors or fresh doctors should be keep in mind. That is the early diagnosis.
Thank you, sir. Thanks a lot. Sir, before concluding our today's discussion, I'd like to hear something from Professor Dr. A.B.M. Jamal, sir.
I have already mentioned many things in this discussion and talked too much. Last of all, I want to express my thanks to Dr. Naurin Sujana for collecting a very nice case, a common case, and a common way of presenting carcinoma of the stomach. This is the most important thing, and this is the unique way of carcinoma of the stomach usually present most of the time in our surgical scenario. And I also express my gratitude to the Renata Limited for promoting their drugs like vitamin D. That is also very helpful. One of the important drugs nowadays we are prescribing, and also the Raj TV for organizing these kinds of learning session, where there is face-to-face learning is almost absolute in every corner of the world. So our junior doctors and medical students get some benefit somehow from these kinds of webinar, and we hope that these kinds of webinar will continue and is of much helpful for our doctors and the students also. Thank you.
Thank you, sir. Dr. Shubina Krishnapal, sir, would you like to add something with Professor Jamal, sir?
If nobody is extra than Jamal sir, that is Jamal sir already completed every corner. Till then, my message to our students and doctors, that is in this corona period, we are detached from the patient, we are detached from the book, we are detached from the clinical attachment. So this webinar arrangement is beneficial for them. I advise every student or every doctor, please attend this type of seminar or symposium or presentation. You can refresh you or boosted up by these types of presentation. Thank you, Sujana, for her nice presentation. Sujana always nicely presented every cases. She is my intern as well as my from third year to up to final year. She regularly touched with us in my ward, so I know her very well. So I think every student should be serious in their activities and work. Thank you, Rastubi and Renata, for their scope by presenting this as a case. And last of all, I think our moderator, they nicely moderate this program and palatable for the every doctors and presenters. Thank you. Thank you, everybody.
Thank you, sir. So this is the end of today's CME. I'd like to thank Professor Dr. A.B.M. Jamal sir, Dr. Shubinay Krishna sir, Paul sir, and Dr. Naurin Sujana Ora. Our today's CME is powered by Renata, and scientific partner was Renata, and powered by Vita D3 and Oral Sim D. And thanks to RAS TV. So good night. Have a good day. Thank you, and Assalamu alaikum.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh.